Good evening, everybody. The situation in Lebanon is critical and almost never seen before in history. By sparing ourselves from talking politics, Lebanon's economic and social spheres are suffering martyrdom. COVID in Lebanon was even harder since the country experienced a devaluation of the currency at the same time. It impoverished the population and made access to healthcare very difficult, or even sometimes unattainable for cash flow reasons, in addition to the immigration of thousands of doctors. Lebanon did not need this cholera epidemic, but it is here. The Lebanese health system struggles to cope. The Euro-Lebanese Medical Society has the slogan, "Together for a healthier Lebanon." We are proud to have excellent relations with the Ministry of Health and particularly with the current minister, Dr. Firas Abyad, with whom many projects are underway. And we congratulate him on all the excellent work done, as well as with his team. We are also proud of our relationships with our colleagues in Lebanon, in particularly with the Council of the Order of Doctors. It is therefore our duty to try to help whenever necessary. Hence, we decided to organize this webinar. On behalf of the ELMS, I am very thankful to all our honorable panelists, His Excellency, Mr. Minister of Health, Dr. Firas Abyad, Dr. Dadoui, who is the Vice President of the Council of Medical Order, representing its President, Professor Bakhash, Professor Yazdan Pana, Head of the Infectious Disease Service at Bisha University Hospital, Dr. Madonna Matar, President of the Lebanese Society of Infectious Disease, and Mr. Alexandre Leridon from Tulip Association. We shall begin this webinar. Dr. Elsa Mhannaut is the treasurer of the ELMS, will be moderating this webinar. Thank you very much. Mr. Minister, it's for you.
So thank you very much for the invitation and the opportunity to describe the situation we have here in Lebanon. Now, let me just put this in general context. When a cholera hits any country, it's not a reflection of its health system as much as it is a reflection of the basic infrastructure that lies in the country. And we have seen that from where cholera started, where we have some endemic, cholera is endemic in certain countries, such as in Bangladesh, with the yearly flooding that are making the situation, the environment, very ripe for cholera infection. Then we saw this also in other countries that had malfunctioning or destroyed infrastructure, such as in Afghanistan, in Pakistan after the recent floods, in Haiti after the earthquake. In the Middle East, I think, we all remember that a couple of years ago, Yemen saw a protracted outbreak of cholera that took over 2 years to be brought under control. And then we saw that there was a progression of this. We saw that in Middle Eastern countries that had archaic infrastructure or very damaged infrastructure, whether because of war or whether because of poor investment in that infrastructure, we saw that we had the cholera in Yemen, then we saw it in Iraq, in Syria, and across the border into Lebanon. In Lebanon, I think we have the same situation as we said, where it came to the infrastructure, and this is what we have seen during our tours and ground visits, where we saw that there is a lot of households that are not receiving clean water. A lot of the pumping stations were not able to work because there is no electricity. And the main problem actually in that was because of the absence of electricity, people were not able to get chlorinated or disinfected water, safe water from the water company. And therefore, they had to resort to untested sources of water, whether it is water that they had from their wells or other sources such as water trucking. At the same time, we saw that we had a problem with sanitation because for the same reason that the water pumping stations were not functioning, the wastewater treatment facilities were not functioning as well with the absence of water. This meant that a lot of the pit holes were not being dislodged. And therefore, when there was some rain, there was flooding, and this increased the contamination of the water sources. And thus, the atmosphere was very ripe for the spread of the cholera. Now, cholera in Lebanon clearly came from Syria. It crossed the border. The first confirmed case of cholera was in a Syrian refugee that had crossed the border 2 days prior to the appearance of symptoms. But obviously, cholera is not a disease of the refugees. I think we also, waterborne diseases, we had seen them before in Lebanon, in the Lebanese population. Almost 8 weeks before the cholera outbreak, we had an outbreak of hepatitis A in Tripoli, and that was followed later with an outbreak also in the area of Sir Dunni. Now, other than the fact that cholera reflects the status of the infrastructure, where it comes to health systems, I think cholera also reflects sometimes a poor surveillance system that then catches those cases quite late after the outbreak has started. And also we see it in areas with poor of these systems where then the outbreak continues without the ability of the authorities to bring it under control. In Syria, typically, we can see that there were 2 outbreaks. One in the areas that were controlled by the government, where there were some, the authorities were still were working, and there were some funds allocated to fight the cholera epidemic. And then we had the areas outside the government control where there aren't any local health authorities, or they are very primitive. And we saw a much wider spread of the outbreak there to this day. So in Lebanon, I think one of the good things that we had was that our epidemiological surveillance unit coming out of COVID actually was well prepared. And therefore, initially, with the first case that was diagnosed, we were able to initiate a strong response. Now, clearly, cholera, we had not seen a cholera case in Lebanon for more than 30 years. And therefore, I think that some of our health facilities were not prepared to see the severe diarrhea that we see with cholera, to deal with those cases. What are the medical protocols that they have to follow? But these are things that we were quickly able to address. And therefore, Dr. Matar will now comment on the situation on the ground. But what is important, I think, to stress is that we are, witnessing a lot of talk, especially after COVID, on issues related to epidemic preparedness and response, and the need to clearly elevate our level of preparedness and response. I think this is something that should be a lesson for all. We are seeing a lot of those infectious diseases coming back. Today, I had a meeting with a delegation from the Fondation Mérieux in France, and I was told by an infectious disease consultant with the delegation that, for example, TB now in France, in the hospital where he is working, is a problem, including multi-drug resistance TB. And obviously, and this is France. Why? Because of the movement, because of the migration, because of the, this increase in travel and exposure. I think infectious diseases will be probably playing a more important role in future health, not only in countries with poor infrastructures as Lebanon. Also, I want to remind you that during these 2 days in the EMRO region, we've had a conference in Oman on antimicrobial resistance. And also what we are seeing, if you look at the genotypic profile, genotype of the cholera, for example, what we notice is that it is a multi-drug resistant cholera, the one we have now in Lebanon, although phenotypically we are still waiting for the analysis. We are also seeing a lot of E. coli in Lebanon that are multi-drug resistant. And this really is quite worrisome, because if we have any outbreak because of the water and sanitation issues in Lebanon, then obviously we might be dealing with something much more serious than the cholera outbreak. So in a nutshell, what I want to say is that I think if we have learned anything from COVID, we have learned the value of preparedness, the value of being able to initiate a quick response. And I think that this is something that is not easy to persuade governments, especially in low resource environment, that to invest that kind of money for an enemy that they don't see, or for a situation that is not there. I think this has always been the problem when you talk about prevention, is that people don't have the sense of urgency, like when there is an actual illness that they could see and that requires treatment. But at the same time, because you are in a low resource environment, then it is essential for you to go into prevention and to putting the right systems to allow you to have early detection, to have surveillance, to be able to quickly act and have control. Otherwise, in my opinion, once you have a very severe outbreak, like what we saw in COVID, for example, in some countries, the price that you pay as a health system is very, very high. So to end my talk, I think, for us with cholera, especially at the moment, we were able, probably because we were very well primed after the COVID outbreak and the pandemic, to have a quick response. And to a large degree, I think that is responsible for why, at the moment, we are having a good response to cholera. But obviously, with the infrastructure that is available, with a disease that is with an organism that is as highly infectious as cholera, this leaves us still vulnerable. And until we are able to really have full control or even eradication of the organism, we will still be in danger. Finally, if the root cause is not addressed, and here we're talking about the infrastructure, then obviously I think we will see future outbreaks, not necessarily of cholera, but definitely we will see some kind of outbreak in the future. And thank you very much.
إلزام ميكرو. إلزام. Okay. Quelque chose, Elsa. Normally we had to have with us Professor Bakhash. He's very sorry he will not be able to be with us. The president of the Lebanese Order. Dr. Da'dou is vice president, was appointed to be with us for this webinar, but she has apparently some internet problems. We'll pass directly to Professor Yazdan Pana. We are very thankful for him to be with us in this webinar to tell us about the new treatment and the techniques for the treatment of the cholera epidemic. Thank you, Professor Yazdan. It's up to you.
Okay, thank you. I couldn't put the microphone on. So first of all, thanks a lot for inviting me. I have some slides, but I don't have the authorization to share them. If you can please let me share them. And again, thanks a lot for the invitation. It is really...
You are now co-host, Professor Yazdan. You can put...
Okay, great. So thanks a lot again for inviting me. It is, of course, a pleasure for me to be here with you. Although for a topic that I would have not to talk about, but anyway, just few words first on the physiopathology of cholera and the virulence of cholera. Cholera is a gram-negative, rod-shaped, non-invasive, many waterborne bacterium. You have more than 200 serogroups. You have two of them that are the origin of the epidemics. One is the O1 LTOR, which is since 1961 in many countries in the origin of the epidemic, and another, which is O139, that was responsible of the epidemics in Asia. The cholera toxin binds on a specific receptor with a massive loss of chloride, as well as fluids and electrolytes. So you have a lot of feces and vomitus. And human is a natural host, and of course, transmission is orophageal. Just to let you on this busy slides that risk factors for severe illness and death are the low level of immunity to cholera in children and non-endemic setting, the underlying condition, malnourished, elderly, children, pregnant, and chronic diseases such as AIDS, but also low gastric acidity, and this is also an important matter. And finally, but at a lower extent, persons with blood group O. And finally, lack of access to early detection and proper treatment is, of course, a risk factor of severe illness. So the incubation period of cholera could be very short, 12 hours until 5 days. 90 to 95% of patients are asymptomatic or have mild diseases, and symptomatic patients who have severe diseases are 10 to 20% of these symptomatic patients. So you have diarrhea with rice water. The mortality rate, as I told you, is less than 1%, but most of them are those who don't have treatment. And really, as I told you, children are at risk of severe diseases, and 50% of deaths occur in children. You have a natural immunity, but it's limited durations, 3 years, although we do not know exactly. And you have, of course, this immunity is serogroup specific. I'm not going to that much to the diagnosis, because usually diagnosis it's not really an issue. And of course, you can isolate from fecal sampler, you can use PCR and TDR, but that is not a big issue. So this is the epidemiology and the people who are currently at risk of cholera, the endemic countries. And what is also important is that we have annually still a high number of cases, and you can see again the number of children, which is very high. What I should have talked to and what I will focus, because that is what Dr. Haddad told me to focus on was the cholera case management. So basically, this is adapted from a MSF slide. It's the importance of the organization. The organization is key in a cholera because it goes very quickly. And you see how diarrhea could be quick. So the way you organize your medical center is extremely important. So to be honest, I haven't myself seen a cholera epidemic, which is probably different than many people who are here. However, I had, when I was going for military service to Africa, I had a course by military folks in Marseille, and usually they have seen a lot of choleras, and they were saying that cholera is really a matter of organizations. If you are well organized, you save lives. The other thing is that probably the most important thing in the cholera is rehydration. Oral rehydration and IV with ringer lactate solution for severe dehydration. So this is really important. And then you have, of course, zinc for children less than 15 years. And this really, the only thing it does, it's decrease the duration of the illness and maybe mortality so in children. And then, of course, antibiotics that is more impacting the duration of diarrhea and the duration of positive bacterial cultures. So the antibiotics are extremely important to decrease the transmission. You can see it decreases the duration of bacterial culture positivity by 26 to 80%, which means it decreases the transmission. What kind of antibiotic you should use in adults? Doxycycline. Which kind of second option you have, ciprofloxacin or azithromycin? And this is also important because we have resistance now to doxycycline. Of course, in pregnant women, you should not use doxycycline, so it will be erythromycin and azithromycin. And in children, again, erythromycin and azithromycin. And those who cannot actually swallow, you can put suspension of erythromycin and azithromycin. So organization, rehydration, and what we really call, which is very important, the WASH, water, sanitation, and hygiene. This is extremely important to try to decrease human-to-human transmission within the household and at the community level for outbreak. Of course, I'm going to talk about the vaccine, but the WASH is extremely important to decrease this. And I will go a little bit more further to describe the WASH. And of course, we talked, and I take Your Excellency, you talk about the chlorine. It should be used when the turbidity is sufficiently low. The contact time, it should be respected. And you should have enough high level of free residual chlorine level in the water. So WASH is extremely important. Chlorine is extremely important. And WASH, that means increasing water access, source-based treatment, household water treatment, latrines, latrines alternative, hygiene promotion, soap and hygiene kits, and environment hygiene. So again, really a matter of organization, and the fact that WASH is, of course, very important. Now, of course, vaccines, but again, with only vaccines, you don't solve anything. Organization, WASH, chlorine, and the use of antibiotics. Here, you can see it's too small, and I'm going to detail it in the coming slides. Here, what you can see is the different vaccines that are available. Here in more details, the oral cholera vaccines available. And again, I've put here plus wash intervention, but because vaccine without wash, it's not good. So here you have three types of vaccines. The Dukoral, which is administered with a buffer solution for children more than 2 years. And when you are a child from 2 to 5, you require a third dose, and you have 7 days to 6 weeks between each dose. These vaccine, given the 3 doses, etc., it's only used for travelers because it's not that easy to use. It's not that much use for travelers, and it protects against cholera for more or less 2 years. But again, I will show you some data. Probably the vaccine that you'd use is the Chanchol and Ovichol Plus, which are the same formula. They don't have any buffer solution of administration, so it's easier. There are more than 1 year. There are 2 doses with 2 weeks between 2 doses. They protect, but I will come back to that, for 3 years. It is said that it should be in controlled temperatures, but in Bangladesh, the safety and immunogenicity was maintained even in high temperatures, so easy to use. And it has been used for mass vaccination campaigns, so this is important. And we have also a recombinant live OCV CVD 103 HG4 vaccine that is for travelers more than 6 years. So these are the vaccines available, and you probably use this one because easier to use and for the epidemics. What about the efficacy? So you can see that basically there are different, and I have used mostly here effectiveness studies than more efficacy studies. So this is a case control study on the first vaccine, and you can see effectiveness 1 to 6 months, and of course this is very important, 84%. And in children, it's lower, 67% in children who are 2 or 4 years of old. And this is again for a short period. For the WC vaccine, effectiveness with 2 doses was found to be 69% for 2 years. In Haiti, there are 2 different studies, 60% for 2 years and 97%, but you can see 97 is for a short period. The effectiveness of 1 dose also has been evaluated, estimated at 80%, but again, we should be careful about this because only about over a 4-month period. And when you look at the longer periods, the efficacy is lower, especially in children, 42%. So of course, vaccine is important, but again, vaccine should be used with the other. We have a basket of interventions for treatment and prevention. We should use them all together. And to just try to finish and give you some perspective for the future, you have here that I'm not going to detail, but some other vaccines that are coming, but they are not yet available because they are under development. So that is the management challenges. And of course, I am happy to respond to any questions regarding this if you wish. Thank you. I don't know. Okay.
Thank you very much, Professor Yazdan Bana. I'm going to move now to Dr. Madonna Matar, and we'll leave the questions to last. Dr. Madonna Matar is an infectious disease specialist and the president of the Lebanese Society of Infectious Diseases. Can you talk to us about your field experience in this epidemic? How are the specialists in Lebanon treating this infectious disease, and what are the perspectives that you can give us according to your experiment in this breakout epidemic?
Now you unmuted me. Sorry, I was unable to unmute myself. Can I share my slides? Elsa, can I share my slides?
Okay.
Thank you. So today I'm gonna discuss with you regarding the situation in Lebanon. The cholera outbreak is a serious threat. It started in the Middle East, and as His Excellency said, it came to Lebanon. It reached Lebanon through Syria. And the Ministry of Health in Syria, they mentioned about this outbreak on September 10th, even though the cases in Syria has been reported much earlier in August, and they have reached a lot of cases, thousands of cases. So in Lebanon, the first case reported by the Ministry of Health was on October 6th. It was, the index case was a Syrian patient. And the second case, also reported the second day, was a Lebanese case. And this is when the outbreak started. So far, on November 23rd, the total cases reported by the Ministry of Health were 4,192 cases, with a total of 20 deaths. And every day we have around, as a total, around between 40 and 50 hospitalized hospitalized patients or bed occupied in hospitals designated for cholera. The origin of this outbreak, it started in Euphrates River, and you know it started in the north of Syria, and the Euphrates River, it goes across Turkey, Syria, and Iraq, and it reached Lebanon through Syria. And in Lebanon, the main problem is the main water supply are through rivers, and we have many rivers in Lebanon that can supply many areas. And you know that in Lebanon, we have, after the economic collapse we had during the last 2 years, we had many problems, such as power shortage, and in some areas they have 0 or 1 hour of electricity a day. We have also a high fuel costs. That's why many water pumps are non-functioning because of the cost and because there are no electricity in many areas. The waste management as well is a major problem in Lebanon. And we do not have a well sanitary infrastructures. We do not have any quality control on about water or waste management. And in the north, in the Bekaa, more than 80% of the populations are living in poverty. And the outbreak started in the north. Until now, the majority of cases are concentrated in the north. We also, in Lebanon, we do not have, because of these shortages, many vegetation and plantations are irrigated with untreated wastewater. And this is also dangerous because sometimes we can sell and have vegetable around all Lebanon that could be contaminated with cholera. Now, what the Ministry of Health set a national action plan. And this plan was set and done with all the national and international organizations and many NGOs, including the WHO, the UNICEF, the UNHCR, and all the one I mentioned here. I might have dropped some, so some could be missing. So these are the main one, and some others as well. So the main issue was working on the WASH. So as Dr. Zaidan said, the WASH is the safe drinking water, sanitation, and hygiene. We, with the Ministry of Health, we focused on chlorination of the drinking water, so providing an adequate drinking water for all the population in all the villages, and chlorination of the water tanks as well, and the water transported through the trucks, because many there are shortage of water in many villages. So they request like trucks, order trucks to come and give and provide waters. So all these trucks now, they set a rule that we need to put chlorination to all these trucks, and they are being followed and surveilled. And also many of the organizations are helping to ensure some power energy for water filtration and pumping in different areas. And many also provides clean bottled water. We are working as well on the surveillance and routine testing. The Ministry of Health has a special department run by Dr. Nada Hossein regarding all the epidemiology and the surveillance system and testing. Education, as educating the public also was one of the important points the ministry have been working on, because public awareness is very, very important in this, in managing this outbreak. And we're trying as well to work on how to direct the waste water for better management and to decrease the risk of spread of the cholera. Another chapter was the case management and hospital support. And the WHO have done a lot, and we as the Lebanese Society of Infectious Disease also are collaborating in all the hospitals with the WHO and the Ministry of Health. And the main goal was to increase the capacity of the healthcare facilities. So they designated 5 governmental hospitals, 2 private hospitals, and 2 field hospitals designated to admit cholera patients. They provide also all the essential needs for these hospitals to manage cholera cases. They developed as well many teams who went to inspect in each area, in each village, and in the hospital settings as well, what do they have, what is lacking. They provide coaching teams in infection control as well as educational teams. They went on the spot to these hospitals and tried to teach and coach their team regarding the cholera, how to manage, how to isolate, how to treat, what is the adequate treatment with many protocols provided. They also ensured the early diagnosis, because it's very important to diagnose early all these cases. They provide also the rapid diagnostic tests, and there were facilities to get cultures and susceptibility of the organisms. And what also is important is that the Ministry of Health offered to cover all the patients that will be admitted to hospital, 100% coverage. So they will take care of the cost of the patients who will be admitted to the hospital. And the other NGOs will take care of the refugees as well, the medical cost and the hospitalization cost. Regarding prevention and surveillance, there has been lots of work also to provide rapid diagnostic tests to support the national capacity. And this was very, very important, because we need to reach an early diagnosis, early warning, early isolation of the patients, and treatment to avoid any complications. And also the communication within the community was focused on, and all the NGOs helped in communicating in each context, and they went on the field to help all the people understand what's going on. The vaccination campaign also was stressed on. The oral cholera vaccination was provided, and we set to give these vaccine to high-risk communities. These included the healthcare workers supporting all these areas, the refugee camps, the high-risk areas as well, all the people living in the high-risk areas, and the prisoners. And the WHO provided us with the first lots of vaccine, 600,000 vaccine first time, and then a second 600 doses. Sanofi offered 13,000 doses of vaccination as well. The total doses of vaccine delivered until yesterday was 309,000 doses. And we decided to give one dose for the time being instead of 2 doses, because there is a shortage in vaccines worldwide. And for now, the WHO we have requested further 2 million doses, and the WHO are securing 1.5 million doses that we hope we will be receiving in the next few weeks or days. The Ministry of Health worked as well on the media communication. We participated in the media communication, as there were some video and some messages for the public, brochures, interviews on the media, because we need to reach the maximum people possible, and this can be done, the easiest way can be done in the media. And it's important to provide the right message to everybody. The WHO, if you go on the Ministry of Health website, you can have every day an update, and you can find all the cases. You go onto cholera in Lebanon, and you can find these tables with lots of other details. And on the table, you can have all the cumulative cases, the confirmed cases, and the deaths, the total number of deaths, plus the vaccines, how many cumulative and how many were provided every day. And you can also have on the map all the areas with tables that will tell you in every village how many cases they have of cholera. And also on the same page, there are lots of information, alerts and announcement. Whatever is new and needs to be highlighted is under this section. So the Ministry of Public Health have really acted very fast. They gathered all the concerned organization, and they are doing like a collaborative work. And to really succeed and be on the long run, we need to do collaborative work and communication with all the teams. So I also thanks all these teams for helping us in Lebanon to manage this outbreak. And while I was preparing this conference, I ran into this statements that the UN General Assembly President have said, and I wanted to share it with you. It's a moral failure that we live in a world with such high level of technical innovation and success, but we continue to allow billions of people to exist without clean drinking water or the basic tools to wash their hands. And this is really sad in 2022. I thank you, and I chose this painting from the gallery of my father, who's a Lebanese artist. So I wanted to choose a flourish village in Lebanon, because according to personally, I will always see Lebanon with such a beautiful painting. So Lebanon will be back, and whatever happened, we always, all of us, I think Lebanese, we always see Lebanon that beautiful despite all our problems. Thank you.
Thank you very much, and thank you for this positive end note. As I said earlier, we're gonna leave the questions to last. I'm gonna ask Dr. Dakdouki, who's also an infectious disease specialist who works in southern Lebanon in Saida, and who is the vice president of the Lebanese Order of Physicians and representing, as we said earlier, Professor Bakhash, who had a last-minute emergency. Dr. Dakdouki, I leave the floor to you.
Okay, thank you. Thank you so much. Thank you, Madonna. Thank you, Dr. Abyad. Thank you, Dr. Haddad. Thank you, Dr. Yazdan. Can I share my screen, please?
Certainly.
Yeah. It's okay?
Not yet. I'm gonna.
Well, it's okay. It's okay.
Okay. I will talk briefly today about the hospital capacity in Lebanon. As you know, hospital capacity, hospitals have a certain number of beds, staff, and physician for patient care. When capacity is reached, it can mean that all their beds are full and all their staff and physician are caring for the maximum number of patients recommended. Regarding the Bloomberg Healthcare Efficiency Index, Lebanon reached the top 25 in the World Healthcare Efficiency, which is a very good issue. In Lebanon, there is 130 hospitals, 29 public hospitals, and more than 80 private hospitals. Most of the largest hospitals are located in the capital of Beirut. This means there is a lack of healthcare system in the periphery. There is a lot of problems which can limit the hospital capacity in Lebanon. And some of these problems regarding the hospitals, the electricity, the fuel and its cost, the fees of healthcare workers and doctors the shortage of medicine and material, the training of personnel in these hospitals, problems regarding the doctors and the healthcare workers. As you know, there is a lot of people who leave Lebanon to work outside because of the financial crisis in Lebanon. There is more than 3,000 doctors and more than 2,500 nurses. The main cause of this problem is the economic crisis in Lebanon. And the third problem, the capacity of people to pay the hospital fees, which lead to unsatisfaction and inability to access the care, the medical care. And in the era of cholera outbreak, we need a lot of disinfection, infection control practices, PPEs, water and sewage management, and also we need a lot of doctors and nurses. For this reason, we need a lot of work. We need a lot of cooperation to work on the hospital capacity in Lebanon, specifically in the era of outbreak. Thank you.
Yes, thank you. I'm gonna move to our last panelist, Monsieur Alexandre Laridan, who's the operating director at Tulip France. Thank you for being with us, and I would like you to tell us about your experience in collaboration in the sending of medication or vaccines abroad, and your insight on this epidemic in Lebanon. Thank you again.
Thank you very much, and good evening, everyone. I would try to be short, of course, as I am the last one. I'm Alexander. I'm in charge of Tulip, as you said, and we are humanitarian organizations. We do only medical donations, and we support Lebanon since 4 years. We work with Red Cross, the Order of Malta, ELMS here. And we were recently involved in medical donation and also in cholera vaccines donations in Lebanon in coordination with Sanofi. Just talking about cholera, we used to deal with cholera in many countries as we work abroad in many African countries. And we can say that cholera cases are growing everywhere. And that's a huge matter for the WHO and for vaccines, as we know that vaccines production is going lower and cholera cases is growing as well. So there is a huge difficulty for vaccines production, and we should not emphasize all our efforts just on vaccines. And as His Excellency Dr. Abiad said, preparedness is the key, of course. In many countries we work with, we saw that WHO support or internal organization support for training for many health facilities, hospitals, and health worker is the key. And I have seen, of course, in the last WHO report that there is a huge coordination between the Ministry of Health and WHO. And there were already a lot of trainings done, a lot of support done by the WHO in this way. So I think it's a very positive thing to me. And of course, medicines are important. We know that in Lebanon, not in Beirut, but in many remote areas, it's sometimes difficult to find medicines or for people to pay for medicines. And international organization may have a role in donation for basic medicines. We know that for cholera, the antibiotics used are quite basic and easy to find. And for medicines, which are not so expensive, could be in any hospital or any health center in the country. I think that's an easy matter for everyone, and international organization like TULIP can support with that. In order to sum up for everyone, as I said, preparedness is the key. The response should emphasize on supporting increasing capacities for health facilities and workers. And WHO has a good role in it. And I see it regarding the situation right now in Lebanon for cholera. I see it as a very positive way, and I'm quite positive for anything that can happen right now. Thank you very much, everyone.
Thank you very much. Thank you to all the panelists. I'm gonna give a few minutes for questions. I'll start with Professor Yazdan Pana and or Monsieur Laridan. How do you think with the current climate changes, the rise in infectious diseases, epidemics, pandemics, etc., how do you think we are prepared? Do you think that healthcare systems should adapt? And how well do you think we are ready to face surges in epidemics and or pandemics?
So maybe, thanks a lot, Dr. Mahanab. I will start, if that's fine, because I have to leave just after, as I told Dr. Haddad. Thank you for the question. So I think that, of course, with the increase in the temperatures, we will have increase in diseases. So, of course, vector-borne diseases, but also diseases related to water or other diseases. We are never prepared, but we really try to now, at least in terms of surveillance, to prepare better, because that's very important to detect. We try in terms of One Health research to try to do more, to not only do this surveillance at the human level, but also at the animal level, because we know that emerging infectious diseases first start in animals' environment. Try to also understand the mechanisms of the spillover, because that is also important. And then third, we need to prepare by trying to, for all these diseases, have diagnostic tools, treatment tools, and vaccine tools to try to identify which one, because most of the emerging infectious diseases are re-emerging infectious diseases. So 70% of re-emerging infectious diseases. So we really try to also consider these countermeasures to try to have on the shelf, and when one disease emerges, to try to use them. And I think all this is very important to prepare. And given that I wanted to leave, I saw one of the questions, and I really think that regarding the resistance, we should be very careful not to use antibioprophylaxis, because that will increase. And of course, as Dr. Matar said, there are now there are studies that show when, as we have at this moment, shortages in vaccine, 1 dose in the short term could be even better than 2 doses, because you can vaccine more people and it gives you a protection. So that is just what I wanted to add based on what Dr. Matar said and one of the questions. So thanks a lot.
Thanks a lot. I'm gonna let Monsieur Laridan tell us about what you think about our preparedness for the prevention and for facing such surges. Do you think at TULIP you have a program or an adaptive measure to face these risks?
So let's be honest, it is not only about Lebanon, it's for all of us as well. We are not ready. We are not ready for such the epidemic right now. I don't believe it. The production of vaccines is too low. The production of medicines also is too low. We have many shortages everywhere in the world. So we should change models in order to find a better way to deal with those new epidemic will, of course, come in the next few years.
Thank you. That's not quite reassuring, but thank you for your insightful opinion. I'm gonna ask Dr. Abiad. There are several questions here about the control of the outbreak and what is the response? I'm gonna take the question of Mr. or Miss Hnaino, who asks, what is the response strategy put in place at the Ministry of Health, and how could we guarantee a sustainable WASH infrastructure in collaboration with other ministries and NGO donors in this emergent plan? And how can we include all infectious diseases? The question is for Dr. Abiad.
So thank you for that question. And I think that it's clear that when it comes to cholera, cholera is not a health issue. Cholera is mainly an infrastructure, especially water infrastructure issue as well. So yesterday we had an interministerial meeting concerning the water strategy for Lebanon. Here we're talking about the provision of clean water and also the management of sanitation in the sense of water treatment facilities and making sure we have the proper infrastructure in place. Now, obviously, this is not the job of the Ministry of Health. This is mainly related to the Ministry of Energy and Water. But clearly, what we see in Lebanon is that years of underinvestment in these infrastructures have led us to where we are at the moment, and that is that these infrastructures are underdeveloped. We have plants that require a large operational budget so that they can continue to function. They require electricity, which is not being provided. Also, in some areas, we have excellent water treatment facilities, but the areas around those facilities are not connected to those facilities because the networking has not been done. So although the plant is there, but obviously you need the networks that will allow the wastewater to reach those facilities for treatment. So I think that the discussion yesterday that we attended as Ministry of Health shows us that it is going to take a long period of time, especially that at the moment we are facing two issues. The Lebanese government, as we all know, does not have the resources to tackle this issue alone. The estimated required budget to invest to be able to bring those facilities up to where we need them, we are talking about billions, not just millions of dollars or euros. Now, concerning our strategy at the moment, our strategy, and here, if you consider countries that have probably worse infrastructure than Lebanon, think about Haiti after the earthquakes, think about Afghanistan now. You see that, those countries were able to achieve containment of the outbreak, not by, they couldn't concentrate on control at the source. So they did a lot of control at the point of use by using mainly chlorination, instructions on how to have clean water, issues related to hygiene, education, and so on. And what that will allow you is that to allow you to have a control of the outbreak and buy time, hoping that this time that we have achieved, the other ministries will be doing their job in, fixing the the networks, fixing the water pumping stations or water treatment facilities, and so on, so that hopefully we can prevent this in the future. I think what is important that even with vaccines, especially with the one-shot policy, we know that this will only be short-lived. We're talking about, as we've heard, a 4-month average of immunity with a single shot. So our strategy at the moment at the Ministry of Health is to control the now, manage the acute part of the outbreak, and then work with other partners to see how we can have an intermediate to long-term plan.
Thank you very much. So as you said, it seems to be a race against time with limited means, sadly. Dr. Maduna Matar, I would like to ask, first of all, Gael Abu Ghanam is asking, which vaccines are currently available in Lebanon? That's the first question. The second one, the Ministry of Health has put online this platform. Do you think it is enough to reach the populations that are quite the first in line concerned with this epidemic? I'm talking about the refugees, the prisoners, the low-income households. Do you think that the information for the prevention is reaching this population? And how is the ministry and the infectious disease specialists managing this information spread? You have to turn on your microphone, Dr. Matar.
Sorry. Regarding the first question was about the vaccine. We have, correct me if I'm wrong, Dr. Abiad, the Shankol and the Evicol. This is the category of vaccine we are getting.
Correct.
Correct. And I showed you the platform of the Ministry of Health if you need information, and this is for the people who can access these informations. But that's why we're working with the media to reach all these places and villages. And even there are teams who goes on the field and try to teach all these people. In the camps, there are always many teams working with them. So we don't rely only on the platform. We're working on many different ways to reach everybody.
Okay, perfect. Thank you very much. The last question is for Dr. Dagdouki. How is the Lebanese Order of Physicians training or giving information now to the scientific population, to the doctors? Are you planning on giving trainings, particular trainings in prevention and care for these kind of epidemics? Now we're talking about cholera, but other surges and infectious diseases that may occur with this economic crisis? You have to turn on your microphone as well.
Okay. On behalf of Lebanese Society of Infectious Disease, under the umbrella of Lebanese Order of Physicians, we try to get our role in education and awareness of the people about cholera and other infectious diseases. As you know, we are facing now also influenza, and we have a lot of cases of COVID in the last 2 years. So we try to get our role in our society to work on awareness mainly and education of medical staff and the people in our country.
Thank you very much. So I already said that it was the last question, but I omitted one by mistake. So Jad Karam is asking, and this is to all our panelists. So whoever thinks they can answer, please do. When attempting to control a cholera outbreak, how should donors distribute the funding resources between programs for safe water and programs for vaccine? So I think he is asking, how do we prioritize in Lebanon given the disastrous infrastructure, sadly? So whoever thinks they can.
Yeah. So I'll answer that. I think that this is a good question. I think that, you know, there isn't a single answer to that. It really depends on the situation on the ground. And I think that the most important part is to get acute control, to have a control of the outbreak as, you know, quickly as possible. Now, concerning WASH, they actually have two roles to play. One is looking at some of the intermediate to long-term solutions that we discussed. But WASH also have a very important role in the acute sense of working hard to provide clean water to the population, whether through, for example, distribution of chlorine pellets, whether through education, whether through creation of these pits that can, you know, make sure that the wastewater is not mixed with the you know, with the water or with the regular wastewater that we have. I think all of these are very important functions that WASH do and support our acute interventions on health. So currently, you know, with the donations that are coming to us, we estimate that almost 2/3 of the donation are going to WASH and 1/3 are going to the health sector. Health sector here, it talks about hospital preparedness, diagnosis using RDTs and others, and you know, going to field hospitals, creating cholera treatment centers, for example, or activities at the PHC. But at the end of the day, you know, even if you do 100% of your efforts on health, without controlling the water and sanitation and hygiene, I think your efforts are bound to fail. Cholera, like other epidemics, are not wars we can win at hospitals. These are wars that we have to manage preventively, preemptively, and therefore I think that you know, putting a lot of resources on WASH is something that is very important.
Thank you very much. Thank you very much for this answer. We've exceeded our given time. I'm gonna let Dr. Haddad end this meeting, and thank you all for your participation. Dr. Haddad.
Thank you, Elsa. Thank you for moderating this webinar. Thank you, everybody. Your Excellency, Mr. Abiad, thank you very much. We are looking forward to work more with you and with the ministry. Thank you, Professor Yazdan. He's not with us, but he made an excellent presentation. Dr. Dadoui, thank you very much also, and through you to Professor Bakhash. Dr. Matar, thank you very much also. You are always present with in our activities. And mainly Mr. Laridan. We are very thankful for Mr. Laridan. We are building with Tulip an excellent cooperation. Our society is committed to health, to a better health and healthier Lebanon. This webinar will be replayed on our website, so you can go to eurolebanese.org. Thank you very much, everybody, and looking forward to see you on other occasions.
Thank you very much. Thank you.